In this presentation, we'll be discussing abdominal pain from bowel disorders. The lecture was written by Ms. Erin Kennedy. Erin is a board-certified family nurse practitioner with a specialty in gastroenterology, and she works in a GI practice in Dayton, Ohio. The lecture is narrated by Dr. Tracy Murray. In today's lecture, we'll be discussing abdominal pain caused by bowel disorders. These are complaints that often present to the primary care provider as the first point of contact. Specifically, we'll examine the differences between inflammatory bowel disease and irritable bowel syndrome and consider the diagnosis of constipation and diverticulitis. We'll examine the presentation of these diseases from history and physical, making the diagnosis, diagnostic testing, and standard treatments. This lecture corresponds with Chapter 11 in your textbook, which should be reviewed prior to this presentation. In terms of forming a differential diagnosis for a patient that presents with abdominal pain, it's important to start by isolating the location of the pain. That being said, remember that the abdomen is a poor historian. In other words, there are no hard and fast rules on the location of abdominal pain and correlation with specific conditions. So here we have a chart that looks at some of the common conditions that correlate with specific quadrants of the abdomen. Pain in the left upper quadrant of the abdomen can be caused by stomach ulcers, pancreatitis, and gastritis. Right upper quadrant pain can be caused by problems with the gallbladder, hepatitis, or pancreatitis. Right lower quadrant pain can be associated with inflammatory bowel disease, irritable bowel syndrome, infectious colitis, and constipation. Left lower quadrant pain can be associated with diverticulitis, irritable bowel syndrome, inflammatory bowel disease, constipation, and infectious colitis. We'll go over differential diagnosis of abdominal pain in more detail after talking about some common bowel disorders. Okay, so let's now take a closer look at inflammatory bowel disease and irritable bowel syndrome. IBS, or irritable bowel syndrome, is a disorder of bowel function as opposed to being due to an anatomic abnormality. Patients who suffer from irritable bowel syndrome have changes in their bowel habits, such as constipation or diarrhea, and abdominal pain, along with other symptoms including abdominal bloating and rectal urgency with diarrhea. In addition, irritable bowel syndrome may be associated with a number of non-intestinal or extra-intestinal symptoms, such as difficulty with sexual function, which would include pain on intercourse or lack of libido, muscle aches and pains, fatigue, fibromyalgia syndrome, headaches, back pain, and sometimes urinary symptoms including urinary urgency, urinary hesitation, or a feeling of spasm in the bladder. IBS is not associated with serious medical consequences. People with IBS tend to live long and in some studies somewhat longer than individuals who do not have IBS. IBS is not a risk factor for other serious GI diseases such as inflammatory bowel disease like Crohn's or ulcerative colitis or colon cancer. Likewise, the presence of IBS does not put extra stress on the other organs of the body, such as the heart, liver, or kidneys. Overall, the prognosis for irritable bowel syndrome is excellent, but patients suffering from IBS should not be warned about it leading to other serious diseases. The major problem with IBS is not that it causes death, but that it changes the quality of life for people who suffer from it. Inflammatory bowel disease, or IBD, on the other hand, is significantly different. IBD is the term used to describe a chronic immunological disease that manifests in intestinal inflammation. Ulcerative colitis and Crohn's disease are the two most common types of inflammatory bowel disorders. UC and CD are both inflammatory bowel disorders that share similar characteristics and causes, but are considered two separate diseases. In ulcerative colitis, or UC, the mucosal surface of the colon is inflamed. This ultimately results in friability, erosions, and bleeding. It most often occurs in the rectosigmoid areas but can involve the entire colon. In Crohn's disease, the inflammation extends deeper into the intestinal wall. Crohn's disease can involve all or any layer of the bowel wall and any portion of the GI tract from the mouth to the anus. Regionally, if the small intestine is involved, it's referred to as ileitis. The term ileocolitis, on the other hand, involves both the small and large intestine. In Crohn's, there is a characteristic segmental presentation of the diseased bowel separated by areas of normal mucosa, which are often referred to as skipped lesions. There is no single explanation for the development of IBD. A prevailing theory holds that a process, possibly viral, bacterial, or allergic, initially inflames the small or large intestine, and depending on genetic disposition, results in the development of antibodies that chronically attack the intestine, leading to inflammation. Approximately 10% of patients with IBD have a close family member with the disease, which lends support to a genetic predisposition in some patients. Now let's discuss how IBS differs from IBD in terms of symptoms, diagnosis, and treatment. We'll start with IBS. The symptoms of IBS result from disordered sensation or abdominal function of the small and large bowel. Individuals with IBS typically present with symptoms that fall into two broad categories: those with abdominal pain and altered bowel habits consisting of diarrhea and/or constipation, and painless diarrhea. Most patients with IBS describe the pain as originating over some area of the colon, with a majority of patients reporting left lower quadrant pain. The pain can wax and wane in intensity and may occur more often following a meal or in a stressful situation. The most consistent characteristic symptom of IBS is alteration in bowel habits. The physical exam in a patient with IBS is usually normal except for some tenderness in some area of the colon, most often the left lower quadrant, the umbilicus, or epigastric area. Digital rectal exam is normal but may exacerbate symptoms in some people. Initial laboratory testing for IBS may include a CBC and SED rate. Because of the low likelihood of uncovering organic diseases in patients with typical IBS symptoms, extensive diagnostic testing with thyroid function studies, stool for ovin parasites, and abdominal imaging is not routinely performed in patients with typical IBS symptoms and no alarm features. However, if testing is performed, the results are typically normal, including barium X-ray and colonoscopy. So any abnormal results should prompt further investigation. Diagnosis of IBS then is based on careful history and physical exam that reveal an increase in bowel symptoms with the onset of pain, relief of pain with defecation, heightened sensation in bowel activity, or sense of incomplete defecation. Symptoms are not accompanied by fever or bleeding. Now, let's talk about IBS treatment. The initial step to successful management of IBS is to make the diagnosis and then identify the symptom pattern for each individual patient. In other words, is it IBS constipation, IBS diarrhea, or IBS constipation and diarrhea? Based on symptom pattern of the patient, therapy may include diet, education, and pharmacological and supportive interventions. Traditionally, much of the effort to treat IBS symptoms used to focus on lifestyle, diet, and reduction of stress. It's important to note that there is no proven treatment, and therapy is often aimed at improving symptoms for IBS. Pharmacological treatment is reserved for patients with moderate to severe symptoms and is directed at specific symptoms. We'll look at a few options in the next few slides. Antidiarrheals should be used as a temporary measure and reserved for severe cases. Loperamide or Diphenoxylate, 2.5 to 5 milligrams every 6 hours, are generally effective. The use of codeine, tincture of opiate, and paregoric should be avoided because of the potential for addiction and misuse. Patients with constipation who have not responded to high-fiber diet, hydration, exercise, and bulking agents may benefit from intermittent use of stimulant laxatives such as lactulose or magnesium hydroxide. Long-term use of laxatives is discouraged. Newer agents have come along that have been approved by the FDA for the treatment of IBS constipation and include Linzest or linaclotide, Trulance, plecanatide, and Amitiza, lubiprostone. These drugs work by acting locally on the atypical membrane of the GI tract to increase intestinal fluid secretion and improve fecal transit. Abdominal pain caused by intestinal spasm can be controlled with antispasmodic agents with favorable results. Postprandial pain can be treated with dicloclamine or Bentyl, 10 to 20 milligrams TID to QID as needed, or hycosamine, 0.125 to 0.75 milligrams BID. However, anticholinergics should be avoided in patients with glaucoma and BPH because of adverse effects, especially in the elderly. Finally, tricyclic antidepressants and SSRIs have been shown to relieve symptoms in some individuals. IBS can be successfully managed by a PCP, but patients who are not responding to treatment should be referred to a gastroenterologist. Now let's move on to inflammatory bowel disease. The symptoms of IBD from the inflammation that develops in the intestine can result in bleeding, fever, elevation of the white blood cell count, as well as diarrhea and cramping, abdominal pain in both UC and CD. The abnormalities in inflammatory bowel disease can usually be visualized by cross-sectional imaging or colonoscopy. In Crohn's disease, there are abnormalities in the intestinal immune response that produce areas of tissue damage. With progression of the disease, fibrosis thickens the bowel wall, narrowing the lumen, which in turn can cause obstructions, fistulas, and ulcerations. Individuals with Crohn's disease are at greater risk for developing colorectal cancer than the general population. Now let's look at ulcerative colitis. In UC, the inflammatory response that occurs in the thinner mucosa of the rectum and sigmoid colon is responsible for tissue damage. Ulcers form in the eroded tissue and abscesses form in the crypts, which become necrotic and ulcerate. The mucosa becomes edematous and thickened, narrowing the lumen of the colon. Patients with UC are at risk for perforated colon and require close observation with a gastroenterologist and possibly a surgeon. The most common presenting symptoms of Crohn's disease are abdominal cramping, fever, anorexia, weight loss, spasm, flatulence, and right lower quadrant pain or mass. Stools may contain blood, mucus, and/or pus. And symptoms tend to increase during periods of stress or after meals consisting of poorly tolerated foods such as fatty, spicy, or dairy. Typically, Crohn's disease has a more insidious and gradual onset. Often individuals will experience intermittent symptoms long before they present for medical attention. The disease is characterized by periods of acute exacerbation alternating with complete remission. Symptoms of ulcerative colitis include bleeding, cramping pain, and the urge to defecate. Stools are characteristically watery diarrhea with blood and mucus. Fecal leukocytes are almost always present with active colitis. In mild forms, patients report 4 or fewer loose bowel movements per day associated with abdominal cramps that are relieved with defecation. Usually, there are no systemic symptoms. With moderate disease, patients experience 4 to 6 loose stools per day that contain more blood and mucus. Severe disease manifests with more frequent bloody bowel movements, like 6 to 10 per day, abdominal tenderness, and symptoms of anemia, hypovolemia, and impaired nutrition. On physical exam with Crohn's disease, right lower quadrant tenderness that often presents as appendicitis can occur. A tender right lower quadrant mass may be palpated. 50% of individuals with Crohn's disease have perianal involvement consisting of anal or perianal fissures. Also, severity is dependent upon the level of inflammation and intestinal lumen obstruction or fibrosis. In UC patients, tenderness is typically in the left lower quadrant or across the entire abdomen, and often accompanied by guarding and abdominal distension. In severe cases, signs and symptoms of peritonitis may be seen if perforation is a complication. Diagnosis for ulcerative colitis and Crohn's disease is made by correlating symptoms with history and physical, and a diagnosis must always begin with excluding an infectious cause for colitis. Imaging studies are necessary to differentiate ulcerative colitis from Crohn's disease, with sigmoidoscopy, colonoscopy, barium enema with small bowel follow-through, and CT as primary diagnostic tools. The treatment of IBD can be very complex and is often managed by a gastroenterologist. Among the drugs commonly prescribed for milder cases of IBD, 5-aminosalicylic acid agents, or 5-ASA, have been used to treat IBD for over 50 years. Research has indicated, though, that these drugs are of little value in Crohn's disease, but are often still used as a first attempt in the treatment of ulcerative colitis. Antidiarrheals can be used for diarrhea with caution, as constipation may occur. They should not be used in acute ulcerative colitis or if toxic megacolon occurs. Corticosteroid therapies such as prednisone or hydrocortisone are given when the 5-ASA products are insufficient to control inflammation and with moderate to severe disease. Steroids drastically suppress clinical symptoms and are given in an 8 to 16 week time period, followed by 2 to 4 weeks of tapering off the medication. Drugs that suppress the body's immune response in IBD, known as immunomodulators, are used in moderate to severe disease that does not respond to corticosteroid therapy. Azathioprine, methotrexate, and 6-mercaptopurine, 6-MP, are the most commonly used immunomodulators. It should be pointed out that this class of drugs can cause bone marrow suppression, and patients are at risk for infection. Finally, a newer class of medications called anti-tumor necrosis factor therapy, biologic response modifiers, or biologicals, are used for patients with moderate to severe disease. Biologics include medications like Remicade or infliximab, Humira, adalimumab, and Entyvio, vedolizumab. These can also increase the patient's risk of infection. Okay, moving on. Let's briefly look at a very common problem that you'll encounter in the primary care setting, which is diverticular disease. Diverticular disease is the term used to describe the inflammatory changes that occur within the diverticular mucosa of the intestine. Diverticula tend to form on the weakened areas of the intestinal wall, usually where arterial vessels perforate the colon. Diverticulosis refers to the presence of small outpouching called diverticula, or sacs that can develop in the wall of the GI tract. While diverticula can present anywhere in the intestine, they're most commonly on the left side of the large intestine and are usually asymptomatic and pose a problem only when they become inflamed or bleed. Diverticulitis now occurs when a patient's diverticulosis becomes inflamed, and when the projection becomes occluded, it can progress to the point of rupture. Acute diverticulitis causes a characteristic left lower quadrant abdominal pain and tenderness. If the perforation is not isolated, signs and symptoms of peritonitis may be present. Symptoms of diverticulitis include, again, left lower quadrant pain and tenderness, fever, change in bowel habits, usually diarrhea, and nausea and vomiting. If a patient can tolerate a more vigorous examination, a firm, fixed mass may be palpable in the area of the diverticuli. Rebound tenderness with involuntary guarding and rigidity may be present. On rectal examination, the stool is usually positive for occult blood. These patients do look sick. Initial laboratory testing can show mild to moderate leukocytosis depending upon the degree of inflammation and infection. H&H may be low if there is associated rectal bleeding. Abdominal X-ray films should be obtained on all patients with suspected diverticulitis to look for free air, which indicates perforation, or ileus or obstruction. Diverticulitis can often be diagnosed clinically, but a CT scan with oral and IV contrast is very sensitive and accurate for a definitive diagnosis. In other words, if the patient presents with a clinical picture of diverticulitis, get an abdominal X-ray to rule out perforation or obstruction and treat empirically. Do not delay treatment to wait for CT confirmation. Some patients will need to be hospitalized due to intractable abdominal pain or vomiting and hypovolemia. Treatment for diverticulitis is confirmed. Once treatment for diverticulitis is confirmed, treatment with 10 to 14 days of metronidazole 500 milligrams TID along with ciprofloxacin 500 milligrams BID or trimethoprim sulfamethoxazole DS 160 over 800 milligrams BID. Close office follow-up should occur upon completion of antibiotic therapy to ensure that the patient has had resolution of symptoms, as complications such as abscess and perforation can occur with diverticulitis. Lastly, let's look at the common complaint of constipation. Constipation can cause significant abdominal pain and bloating. It can occur in the setting of IBS. However, it can also be a symptom of colorectal cancer due to diet or drugs, such as opiates and SSRIs, or can be idiopathic. Some of the common medications that cause constipation include narcotic pain medications, tricyclic antidepressants, iron supplements, antispasmodics, anticholinergic medications, antidiarrheals, antipsychotics, and calcium supplements. How is constipation treated? Increasing the intake of fluids and fiber is often the first step. Vegetables, fruit, especially prunes, whole grain breads, and high fiber cereals are excellent sources of fiber. Bran is an alternative source, although it may cause excessive gas and bloating. To work well, fiber should be consumed with plenty of fluids. Laxative and stool softeners are sometimes needed if changes in diet are insufficient. Miralax is a gentle but effective laxative that is safe for long-term use. Bulking agents such as psyllium and methylcellulose are laxatives that help hold water in the stool and add bulk to it. The increased bulk stimulates the natural contractions of the large intestine. Bulkier stools are softer and easier to pass. Bulking agents act slowly and gently. These agents generally are taken in small amounts at first. The doses increase gradually until regularity is achieved. There are some relatively new medications in existence that are able to treat opioid-induced constipation. One of the most common medications for OIC is Movantik, or naloxegol. This is usually started at 25 milligram tablets once daily in the morning or on an empty stomach. Relistor, methylnaltrexone, is another medication that is available in a subcutaneous and oral formulation. Oral dosing starts at 450 milligram tablets once a day. Lastly, I want to take some time to discuss primary prevention for colon cancer. There are several guidelines available that discuss colon cancer screening. The American Cancer Society says the following: if you are at an increased or high risk of colorectal cancer, you might need to start colorectal cancer screening before age 50 and/or be screened more often. The following conditions make your risk higher than average: a personal history of colorectal cancer or adenomatous polyps, a personal history of inflammatory bowel disease, ulcerative colitis, or Crohn's disease, a strong family history of colorectal cancer or polyps, a known family history of hereditary colorectal cancer syndromes such as familial adenomatous polyposis or Lynch syndrome, hereditary non-polyposis colon cancer. Anyone age 50 or older should have a colonoscopy as part of a routine screening examination to rule out colon cancer. African Americans are more likely to develop colon cancer at an earlier age and should also consider colonoscopy screening at age 40. Now, the American College of Gastroenterology also has a set of colon cancer screening guidelines, and these are the guidelines that I use in my own practice. The differences between the two is that individuals with a single first-degree relative with colorectal cancer or advanced adenomas diagnosed at age 60 years or greater can be screened like the average risk person. Screening is recommended in African Americans beginning at age 45. In the office setting, though, if you have a patient that has alarm symptoms such as unintentional weight loss, rectal bleeding, diffuse lower abdominal pain, new onset of severe diarrhea or constipation, early satiety, or loss of appetite, should be referred to a gastroenterologist for consideration of a colonoscopy and/or upper endoscopy.